Okay, there we go. 22nd of June, 2021, just in case this podcast is found 20 years in the future and you're listening to it. Yeah, we're back in 2021 where we were still kind of dealing with a world pandemic called COVID-19. But thanks for listening, people. Welcome to another edition. This is episode 56 of the Sports Therapy Association podcast. We record it live on Facebook and YouTube, in which case you're welcome to come and join us and ask the guests questions face to face. Or you can listen to it on all favorite podcast players, or you can watch it the recording if you prefer having a visual on YouTube. There are your options. But we do encourage you to try and come on a Tuesday night, 8 o'clock live. And already the Facebook page is filling up. Hi, Catherine. How you doing? If you do come along to the show live, then I can bring your comments up onto the screen so you get a chance to flaunt your social media icon, whatever it is, whether that's a lovely kind of over-the-shoulder look from Catherine there in her new clinic, I think, or you can put your logo up. So it's a great way to network and kind of meet people of soft tissue therapists. You haven't got to be a member of the Sports Therapy Association, obviously. You haven't even got to be a sports therapist. We have plenty of chiropractors and osteos and physios who join us, because more and more, hopefully the message is that it doesn't really matter. We're all kind of healthcare professionals, so we're all dealing with the common factor, which is people in pain. So we're breaking down walls, as they say. So hopefully you can come and join us live. So hi, Catherine, how are you? Hi, Becky, how are you doing? Nice to see you as well. I have no idea why I called you Beckle. And Joan Marshall says, hi, everyone. Looking forward to tonight's episode, as are we. Another fantastic guest and a great subject, which I'm looking forward to. But before I get too excited and forget, let's say thank you to last week's guest, who was Chris Tiley, creator of nevertoooldtolift.com. We had some fantastic feedback of that. It's such a nice subject, isn't it? It's such an easy way, it seems, if you do the right thing, to help people who are either kind of getting on a bit or disabled. And Chris gave us some great information and stories about how to break down those barriers, how to maybe not be as careful as you might think you have to be with some of these people, especially when it comes to resistance training. Still principles which we've heard from other people on the show, like kind of reaching failure, reaching fatigue, inspiring that person, giving them confidence in their body, and so on. So it was a great episode. You can still listen to it on YouTube. You can watch it, or you can listen to it on the podcast as well. And just to mention Chris's book, the ebook, which I had another look through recently. It's because I had an elderly client, a runner, who's just started running, and fantastic. And I actually thought, let's have a look through that ebook again. So it's available on his website, nevertoooldtolift.com. It's like 60 to 62 pages or something like that, I think. And some great information in there, really, really good. Taking you through different training programs, taking you through some of the obstacles you might come up against. And it's great for clients as well. It's one of those perfect ebooks where you can look at it yourself as a clinician, and you can also give it to your clients to look, because it's kind of friendly for them as well. So really good. Check it out on nevertoooldtolift.com. Right. So tonight on the show, also a great producer, and I believe sciatica book, I think, which we'll talk about. But yeah, the back pain special we have, and who better than one of the co-hosts of the Back Pain podcast, which I know some of you are familiar with. Again, I choose the guests on us, so obviously I'm biased, but another great conduit of kind of evidence-informed information without shoving it down your throat, which I'm a big fan of. If you follow the Back Pain podcast on social media, and they're very active in a wonderful way on Instagram and Facebook and Twitter, and Rob himself, then you'll see it's quality information which might shake a few feathers. It might kind of challenge things that you've been taught or learned, particularly for soft tissue therapists, but it's done in a nice way, a good way, a communication way. So yeah, very excited to bring Rob up. As always, if you've got questions for the guest, then just fire away. I've given Rob permission as well, that if he sees something more interesting than what I'm talking about in the comments section, then just to cut me down and say, oh, Catherine's got a good question. I mean, I know Becky already will have a good question. In fact, Becky, you could probably ask a great question now. You may as well ask it now. I know you've got a few up your sleeve. But yeah, do feel free to jump in whenever you like if you've got questions for our guests. But I think that's it for the introduction. Yeah, let's bring up the man himself, co-host of the Back Pain podcast, Mr. Rob Beaven. Hello, mate. How are you?
Not bad, mate. How are you doing?
Very well. Lovely to hear a southern accent, I must say.
Oh, thank you, sir.
Nothing against northern accents, but this is one of the things on social media. It's just, I've heard you before, obviously on the podcast, but it just stands out. I mean, we've had lots of Northern guests. We like to be inclusive on this show. So
Yes.
it's good to have, so as we were talking before the show, it's very important. So it's nice to have somebody representing the South.
Oh, thank you. I'll try my best. So.
No, it's a lovely accent, I'm sure. Already people in the room are thinking, oh, this is very interesting. Although, do you listen to Joe Rogan podcast?
I do. Yeah, I do listen to Joe Rogan.
Slagging off the other day the British accent. He was just
I didn't hear that one.
I love Joe, but he was talking to someone just going, oh, here in the States, we all, as soon as you hear a British accent, you automatically give them 20% more, as if they've got more knowledge and stuff. And he says, as far as I'm concerned, they're great for selling mops and things and the late night shopping channels, but you mustn't be fooled just because they've got an English accent. I'm sitting there shaking my fist.
I'll catch up on that one.
yeah, he was going out to it. But anyway, yes, so the Back Pain podcast, great stuff, mate. Really nice to be able to catch up with you in person. Some fantastic episodes. Let's just give people in the audience here, if you're listening to the podcast, you won't be able to see what's on the screen here, but let me just bring up a little screenshot of like the last 5 or so that's on there. So can you fail physiotherapy, which is the most recent one, and although it's about, well, you use the word physiotherapy, I think you could apply it to any kind of healthcare provision, really.
Yes, yeah.
Really interesting episode. But look at further down the list, my sciatica success stories about sciatica. What does manual therapy do? What does it not do? How many times we talked about this in the show? What difference does posture make? So huge, really, really interesting and nicely presented information there for everybody to have a look at. And obviously quality guests as well, of which I've already shared a couple. Dr. Mark Laslett, for example, we had on the show, I kindly stole from these guys, which was a nice introduction. But we had a great talk about that on SIJ, dysfunction and pain, and the difference between those. So yeah, great show, mate.
Thank you, mate.
Really nice. I think the best thing to do, first of all, for people who aren't aware of you and your co-host, how did it all start? How did the podcast come about?
Great question. So myself and my co-host Dave Elliott, we're both chiropractors. We graduated together 10 years ago. I think we did now 2011, 2012. So 9 years ago. And then we were just, we listened to a lot of podcasts. There were so many podcasts out there for us therapists, and they were very evidence-based podcasts and lots of that. There was very little out there for patients. And as everyone watching knows or listening knows, there's a world of misinformation and poor information around there, specifically aimed at patients. People trying to sell them products and people trying to, get them on board with whatever they're trying to sell them. And we were just fed up of it, basically. So we wanted to put some quality information out there, evidence-based information with experts. So we just wanted to speak to experts. We weren't trying to position ourselves there as the back pain experts. It was just, we wanted to get the voices of the people who really knew what they were talking about and get that across in a patient narrative. And then all of our, friends, colleagues, other therapists could then promote these messages and then put them out to their own patient bases. So then we're all singing off the same hymn sheet. So that's kind of where we wanted to go with it. And that's the way we're still running with it.
It's interesting. I'm sure a few people listening to the podcast or even in the audience there, the one word they've still got in their head ringing away, the rest they probably didn't hear was like chiropractor. This guy's a chiropractor and he's talking about lower back pain and back pain. Surely, I mean, that's got to be a juxtaposition there of, we were talking a little bit off air about, it is interesting for me because I've got my biases as well, that you are both chiropractors and yet you're kind of dispersing new modern concepts to do with back pain. Do you feel there is still a misinterpretation of chiropractors and a bit of a stigma attached to you guys?
Yeah, I think there is definitely a misinterpretation. I think that, and I wasn't aware of this misinterpretation until kind of probably more after I graduated. And this comes about from old historical models. Chiropractors were famous for manipulation, back cracking, whatever you call it. Chiropractors call it adjusting. And that's been portrayed by the media, by, television, film, Simpsons episodes, all of those, things kind of portray this as chiropractic being synonymous with manipulation. And that's not something that we learned as chiropractors. That's where I kind of sit in this juxtaposition, because that's not what we were taught. Everything wasn't pinned on manipulation. And the way we see it and why I promote it now is chiropractic is a profession. It's not a type of treatment. So as with all of the therapies, you see a chiropractor, you don't have chiropractic done to you. You see a chiropractor who does who has a myriad of tools which they can use at their disposal. That might be, cognitive behavioral therapy. It might be talking. It might be exercise. It might be manipulation. It might be hands-on massage, whatever it is. It's lots of different tools at their disposal. And so that's what chiropractic is to me. It's a profession that deals with musculoskeletal injuries as opposed to a type of treatment.
That's really interesting. It's a good distinction as well. I wonder it's one that makes our listeners think of, when do people have sports therapy done to them? Even the word therapy, well, I pick on every single word. I'm terrible. I go over the top. But even as soon as you call something therapy, it's like that's something you have done to you, and you kind of lie down and receive it. But it's interesting, isn't it? Yeah, you shouldn't be going to someone for physio or for chiropractic or for sports therapy. It's about just as much talking of what they're going to do with their hands. Yeah, it's a wake-up call, I think, for some people. It is just another classic example of social media putting these images of people with hammers and banging into, spines and stuff, and it's just a bad interpretation. It's casting everyone with the same brush, and it's terrible.
For sure. And your identity is what you do on a regular basis. So, and if this has been portrayed by chiropractors for 80, 100, however old the profession is, 120 years or something, and if they have, and very much we know that the chiropractors have leaned on manipulation, but we know that we've evolved, and this is, everyone evolves, professions evolve. Osteopathy used to have equally spurious roots as chiropractic did, but we've changed and we've grown. But that old historical narrative kind of does still hang around, a bit like a bad smell.
It's actually talking of 80-year-old chiropractors. Oh no, you're not quite that old, are you, Robert? There you go, Robert, chiropractor here.
Yeah, Raleigh, also podcast guest.
There you go. And thanks for joining us, Robert. Good to have you here. Is that there's a message to sports therapists there. If chiropractors have evolved and osteopaths have had to evolve, then maybe when we talk about sports therapy and massage having to evolve, maybe we've been a bit slow with regards to that. And there's nothing wrong with it. It just makes you don't have to throw everything away. You don't throw everything away. You just kind of pick what works. And when you understand, make it less wrong, as we like to say. Yeah. Make sure what you're doing is less wrong. Cool. And there's one question here already, just before I forget. Rebecca Cross has said, how can we find the Back Pain podcast, please? What's the easiest way to find it?
Well, you can visit the website, thebackpainpodcast.com, or it is available on every podcast player, Spotify, iTunes, Castbox, Stitcher. I don't know, you might know some more, but everywhere you find a podcast, it's there. If you don't know where to find a podcast, if you visit the website, there is a few links there which you can click on. And if you have a smartphone, it should take you directly to that location.
There you go, Rebecca. Yep, everywhere. Just download an app to your phone. Sometimes on Android, you might need a third-party app like Pocket Cast or something, or Stitcher. But yeah, once you do that, it'll appear on all of them. Right. Okay. So I gave you a rather daunting task when we were chatting about how to get the best out of this hour with you kindly giving us your time. So we thought, okay, what about your whole show is about back pain? So we're going to lower it to, that was no pun intended, we're going to kind of bring it down to lower back pain, because we could talk about the rest of the back, obviously, but it's going to be about lower back pain. And I asked you to have a think maybe about the 5 most common misconceptions you see, and that you kind of, obviously your podcast will mention a few times because that's what you're trying to address. You kindly came up with 5. Yeah. I don't know whether to say those 5 now. Whether
do it.
What do you think the hook is?
Yeah, no, just give a teaser, I think.
Oh, what, maybe the first 3 and save the last 2? Are they in any particular order?
No particular order. No.
Okay, in no particular order. So we'll mention the first 3, and then the last 2, you can see whether you can see if you're listening whether you can guess the last 2 when you hear the first 3. So what are the first 3 going to be?
So the first one was about manual therapy. So talking about bones don't go out of place, and what actually happens with manual therapy. We're not breaking down adhesions and scar tissues kind of with our hands.
Okay.
Second one, we're going to talk about posture, which is a huge topic. We could talk about that for an hour. And then third one, to talk about MRIs and imaging.
Okay.
And the impact on pain and dysfunction, and when to refer, and a few bits like that. How does that sound?
That sounds great. And then we're going to have 2 surprise ones at the end to shock you. We'll put it out there as if it will. Wicked. Okay, mate. So that's fantastic. And thanks again for giving us your time to talk about these. So let's start with the first one. And again, questions in there. As soon as you feel like you've got something to ask, then fire it away. So misalignment and things like, releasing and fixing what is apparently misaligned. Talk to us.
Yeah. So, manipulation, bones going in and out of place. This is a really hard kind of myth to bust. And especially as a chiropractor, I probably get this from patients more so than people that aren't chiropractors. Obviously, lots of professions provide manipulation as a type of manual therapy, but I'll probably get it more, you're a chiropractor, you must need to put this back into place. And this has come about, I think, mostly from lazy language. I don't believe that any therapist who's doing manipulation truly believes that a spine has gone out of place. You know, I think it's, you know, we know that the amount of trauma needed to separate a joint, you wouldn't need an adjustment, you would need a spinal surgeon to realign a joint if it has actually gone out of place. But also we must remember that it can feel like this. So from a patient perspective, you know, if you're moving, if you're stiff, that kind of stuck feeling, it can feel like a joint is out of place. So, you know, we must not kind of ignore the kind of patient narrative. But the issue is people ask, well, what's the harm? You know, what's the problem with saying to a patient, oh, it's out of place, we realign it? And well, firstly, I think this has it gives an overly structural blame to a pain. You know, we know that low back pain, if we take low back pain and most pain, is so multifactorial. You know, it's very rarely down to a singular structural cause, you know, and that's the same for a lot of pain, but very rarely is back pain down to one structural cause. There are so many things that can impact back pain. But if we have this singular structural cause and we have this fear that our spine is going to pop out of place or our pelvis is going to go out of alignment, this can lead to kind of fear avoidance behavior where we avoid certain activities, avoid tasks for fear that your back is going to go out. And then possibly a dependency on a certain type of treatment or a certain type of practitioner to realign your spine and kind of pop it back into place. And this is not what we should be doing as therapists. You know, as therapists, whatever title you use, our job is to show patients that their spines, hips, muscles, joints, tendons are hugely strong. You know, bodies are strong and stable and they adapt to load. They like load. They don't go out of place when you put your shoes on or you go for a tennis serve. And then if someone's got these beliefs and then we're telling them that they need to go and deadlift or they need to go and do a glute bridge or they need to stand up and sit down a few more times, you know, they're not going to do that if they have this fear of, you know, things going in and out of place. So we should be encouraging more movement and encouraging this narrative around we're strong, we're stable, we're just a bit sore right now, you know, and that's kind of the way I, you know, go about it. But it's a difficult conversation to have with patients, especially when they have these beliefs. And I think it's important not to dismiss patient beliefs. You know, when someone comes to me and they've had back pain for 30 years, and every time they have a flare up, they see a chiropractor, an osteopath, a physiotherapist, a sports therapist, whoever it might be, who does some manipulation and they feel better. It would be completely remiss of me to sit there on minute one of meeting them and say, no, that's not how it works. I don't do that. You know, so there's an element always of meeting a patient kind of in the middle. So you gain that rapport. And this is the hard part that we all have as therapists, is when we're sat in the room with a patient and they're not necessarily requesting something, because you can't dictate your whole treatment by what a patient wants, but it guides your treatment. And if you negate what they say on day one, it's going to lead to poor outcomes. You know, they're going to leave unhappy. They're going to go see someone else who might do what they want. And that practitioner might not be as informed as you. So they might then be further down that narrative. So I often might potentially do a treatment that might not be my first choice. That might be massage, that might be manipulation. Obviously, of course, if it's safe to do so. But in order to meet the patient in the middle, to gain that rapport, to help reduce pain, and we know the other things that manual therapy might do, to then get them on your side. And then once they're on your side, they might be a bit more pain-free. You can then start to introduce a different narrative and have this conversation around, actually, that doesn't quite do what you think it is. And actually, it's a stretch to a joint. And you can go down that whole kind of line. This doesn't actually realign or put anything back into place. And you can open that gate and open that door. And this isn't a conversation always for day one. Some people will be open to it, some people won't. And this is the skill that we have to have as therapists to, you know, pick your moment and choose your patient.
Yeah, I mean, it's really tricky, isn't it? Because like you said, if you use structure to explain the pain solely, then it also gives you quite conveniently the chance to, but I've got these tools normally with my hands of putting you back into the right position again, whether it's breaking down a knot or stretching a muscle or manipulating and putting the spine level again and all this sort of stuff. So I think what sometimes people are scared of is, if you take that away, then what are you supposed to fill it with? Especially in the case of a massage therapist who maybe has got the client booked in for an hour, and if they've over here, for example, in the UK, a lot of level 5 massage therapists, once they get into sports therapy, it's all based around more manual technique ways to, like myofascial release, of making that shoulder the same height and making the pelvis the same height. It's all based around symmetry, and that's kind of the model that's used. So you mentioned kind of, I don't want to gloss over this, because I know that I get emails from listeners who, when we start saying, oh, there's other factors that could be causing the pain, they find that quite, well, what then? What are we supposed to, can you expand a little bit on that when you said it's not just structural stuff, which could be related to the pain that the person's suffering from their lower back?
Yeah, I mean, well, obviously structure can play a role, rarely, but it can, you can have a traumatic injury, which can be a structural problem. But the vast majority of the low back pain that we see is non-specific back pain. And that means not that we don't know what's causing it, but it just means that we can't nail it down to a single structure. So it's a combination of lots of different factors. So that's kind of where we come from in the lower back. But then so many factors, and, as another spoiler, we'll come on to talking about kind of pain and damage later. But so many factors influence the brain's role in pain, and that can be your mood at the time, it can be your depression levels, it can be anxiety, it can be your past beliefs or your fear of certain movements, and all of those can play a role. So that is why this addressing of back pain has to be this multifactorial approach, rather than reliance on this single structural cause. If you're not addressing these other issues in kind of chronic back pain, and that might be, I said, fear and beliefs is a really good example to kind of pick up on. If someone's fearful around a certain movement because they think it's going to hurt, then they never do that movement. And we know that avoiding a movement is not a really good place to do. The spines are meant to bend and lift and twist and do all the things that we're designed to do. We're not meant to avoid a certain movement for the rest of our time. And I'm sure everyone listening has probably had a patient who has said something along the lines of, I was told never to bend forward, I was told never to pick up anything heavier than a shopping bag or a bag of flour. And this might be an 80-year-old patient who's been doing this for 60 years because she had a back injury when she was 20. And that's what we used to say to patients 60, 70 years ago. Not that I was here, but I'm sure that's what we used to say to people based on what patients have told me. So these are the other factors that kind of play a role. So, and this is not me, I'm not anti-manual therapy. I'm not saying that this doesn't work. And for people that then do a lot of manual therapy, that's not a problem. It works. People get better, and it's not the problem is not the manual therapy itself. The problem is how we're explaining it to patients, and promotion of manual therapy to act as a pain reliever, to help people move better, to help go about their activities of daily living. Brilliant. That's what we're doing it, and then we can then back up those changes with exercises, with rehab, with movement, with lifestyle advice. So all those tools that people still have with their hands are still very valuable tools. We're not, I'm not dismissing that by any way.
Great stuff. Yeah, it is. It's one of the biggest challenges which I try and overcome quite early when I'm teaching therapists who have learned to base everything on seeking symmetry and alignment and imbalances and things. But once you've got that out of your head, it's like you open this box of, oh wow, so if that's not right, I've got all of this I can look into, and it actually should be quite exciting. But it's a tricky box, which in the past has made quite a good business model, which I don't think we can forget. It is convenient, people will keep coming back, but it's an ethical thing, isn't it? Becky's got a little, let's write down here. Let me get rid of that title for a second. Becky says, I'll bring it up so people watching can see it on the screen. I agree that informing our clients with the right narrative is important. However, have you experienced with having these tricky conversations with fellow health professionals that are also working with your clients? See, she's done it straight away. I knew she'd come up with one. It's true. When you're working together with other professionals and they're maybe on a different page, how does that work out for you?
It's difficult. It is definitely hard. And in a similar way to patients, I'm not one to, kind of talk down other practitioners, because as I said, things work. And if a patient's out there feeling better, I'm not going to tell them that, what that other chiropractor doing was nonsense. That's not my job. As I said to you before, what's the phrase? No one wins in a mud fight. No one comes out clean. It doesn't help. But no, it's a tricky conversation to have. So my argument is I provide the good information. I put it out there in the forms of podcasts, blogs, Instagram posts. If people choose to adopt that and bring it on, then brilliant. But I'm not there going to, I think taking the right course and promoting the right information is the right way to do it. With colleagues and other people who might ask me about it, then I'll kind of say, well, what do you think about that? Why do you think that posture plays a role? Or why do you think that core stability is important? Why? And kind of have that conversation as opposed to shutting down someone's beliefs. But no, there's no easy way to do it. I fully agree, Becky.
Yeah. And that's what, I mean, sometimes it is a case of if you can't, not everyone can have nice, calm, rational debate. It's not something we're born with a lot of the time. Sometimes people don't like confrontation and they start getting angry, or they just haven't got the experience to put words together. Not everyone's born like that or develops it when they're younger. So I think sometimes like directing people to maybe one of your podcast episodes to somebody who does manage to explain it in a way which you can only dream of doing it can help.
Yeah.
And just giving someone a link, have a listen to this. I can't explain it myself because of my limitations, which people love hearing about, people saying their own limitations, but listen to this and see what you think about it. We'll chat about it. I mean, that could be great. So that can work, I think.
People get defensive.
It's the times we live in, isn't it? We were talking about it before. People love an argument, and like we were saying off air, it's an attack against your identity. There's so many arguments these days on a variety of topics, but as soon as you disagree with someone, it's like we think they're attacking us, and that's what I stand for. But we're not. We can't be what we believe in because we change our beliefs all the time. We develop and change. So
exactly. And if your whole identity is pinned to a particular treatment type or a particular specific type of manual therapy, and someone's questioning the ground you're living on, and you're on shaky ground, then you've got nowhere to go, and your entire dependency is based around this particular technique, then you're going to get defensive. You sank a lot of money, effort, time into doing this. So people are going to get defensive around it when, that's on them really at the end of the day.
Yeah, it's tricky. And again, the person I always quote on this, we had him as a guest on the show. Walt Fritz was a brilliant example of somebody who had the whole world attacking him when he was like working with the pioneers of myofascial release and stuff. And then he had to kind of sit back, and he was attacking back, and then he just listened to it. He analyzed in his own time, went to his man cave, or woman cave, or just a cave. And he started thinking, actually, I'm right. Yeah, they're right. I have to evolve. I'm going to stop. I'm trying to seek this ideal posture and stuff.
Yeah.
You can turn it around, but it just takes maybe some time. And anyway, Becky, let us know if you've had a problem. Come back with another. It's a great question. Really good. It is true. And one where I think a lot of therapists go wrong. They start jumping on a horse and kind of trying to soapbox it, and it doesn't work.
For sure.
It doesn't work. Okay. Because we've got 5. If you've got any questions about misalignment or how to get away from that kind of model, then obviously leave some questions in the comments. But I think it will take us quite smoothly now through to posture, because it's kind of a link there. Tell us about posture.
So posture is something which probably everyone watching has learnt about in terms of postural assessments using plumb lines. I remember standing there in day 1 university. Plumb line, your head should be in line with your ear and your shoulder and your hip, and all those type of things. So everyone's probably done that. But the question is, does posture matter? Should we be worried about posture, or should we be trying to influence it or kind of change it? Well, firstly, there isn't actually consensus on what is good posture. So no one knows kind of what is good posture. If you ask most people, they will think that it means sitting up really tall, kind of bringing their shoulders back. And that's not actually, we know that, from the evidence that isn't actually correlated with less back pain. In fact, actually conversely, people who spend most time thinking about their posture and trying to sit up straight are more likely to have back pain than people who don't think about their posture and kind of slump down. So the way I explain posture to patients is, it's not the position that you're sat in, but it's the lack of movement from said posture that's the problem. So any position that you sit in for 8 hours is not good. Whether that is this perfect, computer posture, the sun's right in my eye, sorry. Whether it's a perfect sat up tall computer posture, that we're trying to emulate with everything, or whether it's a slouch posture, go and sit in either of those for 8 hours and kind of see how comfortable it is. And I think a lot of these beliefs and expectations came around from societal norms and kind of societal expectations. And we know that the kind of the perfectionist, beautiful image of someone is always in that kind of perfect posture, whether that's a male or female. Sitting up tall is correlated with looking beautiful and extra confidence and all these type of things that go hand in hand. So I think the only time it might be appropriate, and I think Kieran O'Sullivan said this, the only time it's appropriate to really think about your posture is if it's a first date, or if you're at a job interview, and you're really worried about looking confident or looking attractive. That's kind of the things which posture is related to. And it also doesn't really correlate to non-recovery. So if we're telling people to improve their posture to have a better outcome of back pain, that also doesn't change. People who then spend a lot of time sitting up tall, trying to think it, sit up tall, pull their shoulders back, thinking that's going to help their back pain, it actually doesn't have any benefit to improving their back pain. What does make back pain worse is worrying about your posture. That's one of the other things which we know that has an impact, worrying about it. So it's a huge topic. It's hugely ingrained in society. Everybody would have heard a patient say, it's probably my posture, I'm worried about my posture. But, it doesn't correlate very well with lower back pain.
Which again is going to be tricky for particularly kind of newer sports massage therapists who have been told to look at lower back pain, check for lordosis, check for anterior pelvic tilt. So, I mean, where do you, as a practitioner then, where do you sit with like lordosis? Should it be regarded? Should we talk about it as something to look out for and measure, or?
Personally, no. Outside of this, I think looking for things like spondies and bits like that as well. If someone's got a very big lordotic posture, and I believe there might be an increased risk they might have something like a spondy if it kind of fits the history. But those are kind of by the by. Generally, no, it doesn't really play a huge role into my assessment. I will look at how someone moves through that posture. So can they move into full flexion, full extension? Are they stuck rigid? Or are they fearful of moving outside of that posture? So are they in a big lordotic posture because they're in a lot of pain and they're fearful of kind of going to flexion? But in terms of just looking at someone's posture, will that have an impact down the line in terms of pain? Then no, it's not something that I will put much benefit on at all. I won't do a plumb line type assessment on someone. It really, for me, and that goes for anyone, whether they are elderly, young, sports athlete, whoever. As I said, there are a few things looking at scolioses and kyphotic type Sherman's conditions, and those are structural conditions aside. But generally, no, it doesn't play a big role kind of day to day in my treatment. If someone has a preferred posture to get them out of pain, I don't mind them being in that position. It's perfectly normal to avoid a painful position for a time period. If that's sitting up straight, if that's slumping, don't mind at all. They're fine to do that. But what is important is we introduce that posture at a later date. So if they're fearful of flexion, I don't mind if they don't flex for a few days or a few weeks, but it's important that we bring that back in at a later date to grade that recovery and grade that improvement.
Yeah, so again, it's kind of, it's for a lot of younger therapists going to be a bit of a surprise. But I thought what you said was interesting was, okay, you look at somebody, but it's interesting to see if they are in a particular posture, whether they can move into a new one. Because sometimes in life, everybody is going to have to flex and extend sometimes, for different tasks and things. So it's interesting. Still do. I mean, I teach quite a low level because I like getting in there early thinking I'm going to change the world, but I have to teach them these assessments so they can tick the boxes, pass the exam. But straight away I'm like, okay, look at them, fine. But rather than judging them on the static position, just out of interest, see if they can adopt a new posture. Rather than saying, oh, they've got fallen arches, see if they can, keep the contact with the floor and lift those up. If they can, so what? It's just their position. Happy position is like that. So
I think you have to have a starting point. So there's nothing wrong with assessing that posture and learning that posture, because you have to know, I don't like the word normal, but you have to know what people look like, and you have to know what flexion extension looks like. And as you said, what a fallen collapsed arch, moves like, what lumbar flexion extension looks like. You have to know what people look like when they've got no clothes on. That's our job. So it's not a bad thing to be doing that. It's just the narrative. Again, we use the word narrative around explaining that this is inherently a problem and fixing it will get you out of pain, which we know doesn't have a big correlation.
What about the idea, because I know there's a lot of stuff built around the position of the pelvis. It's a classic kind of marker, and where correctional exercise is then sold as the idea of how to get you to this norm. What about the idea of a neutral pelvis? What do you think when you hear about that, this idea of having the center bit as the sweet spot where everything's going to be okay?
No, so again, I'd go back to the same answer for kind of like a lordotic posture. It has very little bearing kind of on pain. People come to us in pain, out of pain, and we know that they have a huge variance in kind of these, pelvic tilts, the anterior pelvic tilt. Similar to the posture, correction of said anterior pelvic tilt has very little to do to improving back pain. What is more important is the ability to move through that range of motion, just like that kind of lumbar flexion extension, that anterior posterior pelvic tilt. I remember doing that in year one, kind of looking at pelvic asymmetries and assessing, pelvic movement, and which you probably spoke about with Mark Laslett, the ability to kind of palpate movement around the pelvis. The pelvis doesn't move in the way that kind of I was taught, and that was something for me. I remember assessing it and saying, oh, this is stuck on this side, it doesn't move well. And can we palpate a millimeter of movement through an inch of bone, muscle, fat? The expert Mark Laslett says probably not, and I kind of lean on his narrative around that a lot when I'm explaining that to patients. But it is really hard when you've been taught all this, and really hard to undo it. But I think that what all these schools do really well is they teach people to question. And I think that's what, you do well through things like this podcast. And that's what, the good schools do, is they teach people to ask questions and say, okay, so why does this cause pain? Why doesn't it cause pain? Why does this patient have this big anterior tilt, but he doesn't have pain in his low back? He's coming to me with shoulder pain. And that's what, as good therapists, we should be doing. And that's what we should be going and looking for, using things like podcasts and research papers and asking people on Twitter, for the evidence. We've all been in the same situation. We've all had these doubts and we all still do on a daily basis. I'm not saying I'm immune from this at all. So asking people, so having that as a skill to fall back on, I think is really important.
Yeah, that's really good point. Yeah, once you do get past that kind of norm of thinking, oh, you've got lower back pain, oh, I see you got a big anterior pelvic tilt here, well, that's probably because you got tight hamstrings because you've been sitting down all day, so this is what we're going to do. Once you get rid of that blueprint response, then there's probably initial fear of, what do I do then? I don't know what to do.
But that doesn't mean what you were going to do for that isn't necessarily going to help that patient. So if that means you're going to do some massage, that means you're going to do some stretching, if that means you're going to give some corrective exercises, that doesn't mean that those things don't help that patient. So there's no problem with that. It just doesn't necessarily mean that they do what you think they were doing. And I think that's the kind of the difference. So it's not, if someone's listening to this and thinking, well, I've been trying to correct this, you haven't been necessarily doing something wrong. And I'm not standing on a high horse trying to say that. You've been helping patients. Brilliant. That's fantastic. That's what we're here to do. It's just asking why it's helping. And I think that's the kind of the question that we all have.
Yeah, that's very good advice. I just think it's worrying this is where, particularly in massage at the moment, we're always putting more, the subjective, listen to a patient enough and they'll tell you what's wrong with them, and listen to them some more and they'll tell you how to fix them kind of thing. Because I think if you jump straight into that structural objective measurement thing, then you ignore the fact they're only sleeping 3 hours a night, or they don't eat until dinner time, all these things which are probably winding up the nervous system and keeping them in that state of pain. And
well, they just got divorced and they're also moving house, and
exactly.
They've had a death in the family, all those things.
Yeah. And often a lot of the things which they won't tell you excuse me, they won't tell you until you visit them for a month or something, and then they might tell you about how their teenager is doing this and that, and they're just totally wound up, and you think, well, how am I going to help them with that? But the fact they actually tell you and share it, and then maybe you have got some cards or some people relate or something, or some kind of like someone who could talk to them about it. And so we're quite big on here. And the more I do these chats with different guests, for like Jack March, from rheumatology, and we had some great pelvic health physiotherapists as well, both from male and female backgrounds. And it really has made an effect on me this year, really realizing that massage therapists have got a really huge responsibility, in the sense that a lot of people suffering from pain for something systemic, who typically don't get diagnosed, including hypermobility, and we had endometriosis a couple of weeks ago, they're probably walking through our door to us first of all, because they're thinking, oh, a good massage will help me, I need a good massage. And it does help, but they're masking maybe getting a proper diagnosis by visiting the right sort of person, and they're kind of putting up with symptoms. So I'm quite excited by the fact that massage therapists, we enjoy them coming in, we enjoy laying hands on them, we enjoy the sensation of giving them massage and stuff. But if we ask more questions at the beginning, rather than thinking, oh yeah, this is broken, I'm going to fix it, then we could help loads of people get to the right person, help bring down these 7 to 10 years of bad or misdiagnosis, with things like that. It should be exciting. I'm hoping massage therapists listening to this understand that. It's a great place to be. Because that's all we wanted to do, isn't it? Healthcare professionals. We want to help people.
Yeah, that's what we're there for. Yeah, 100%.
So yeah, cool. Right. Tina's got a question here. It's good with posture and work kind of assessments, because a lot of blame is put onto your position at work, isn't it? Having the right computer height in the chair and stuff. But Tina says, I'll read it out. Let me just get rid of that on there. Hide that. So Tina says, I'm a relative newbie, but I'm seeing a rise in occupational assessments for back pain clients, swapping out chairs for stability balls and standing desks as a permanent until resolved. I'm trying to get the movement message across is challenging. Have tried to contact, but met with resistance. Any recommendations, as in work hours, the individuals listen to? OH, what do you think OH stands for?
Occupational health.
Occupational health, there we go. So yeah, there's a little bit in there regarding our stability balls or standing desk a solution, and trying to help probably line managers and people understand what the cause of their staff's lower back pain is and how to give advice. Yeah. What do you think,
So
Rob?
that's a good question. So I would put this, because everyone gets asked this question a lot. Should I change my chair? Should I change my desk? Whatever it is. I put it to, as I said, to most patients, this is what I would say, I don't mind what chair you have, as long as you get out of it frequently. So that could be a $9.99 chair from Argos, or it could be a £1,500, Herman Miller, whatever office chair is. Doesn't matter. If you're stuck in that chair for 8 hours a day and you don't move, it doesn't matter however your setup is, you're going to be uncomfortable. That's normal. Look at a plane seat, they're pretty upright and pretty normal. You might say even they're in good posture, but you're uncomfortable when you sat on a plane for 10 hours because you're not moving. Exactly the same thing. So I'm a big advocate of anything that involves a bit more movement. So that a sit to stand desk is a brilliant example. Treadmill desk is another example. You get these mini treadmills that people put under their desk and they walk. I've even seen a bike desk or stability board desks. Now, are these perfect for everyone? No. Some people get more pain when they're walking. Some people get more pain when they're standing. But, what doesn't help is being static for long periods. So that is what kind of needs to change, is that, are you stuck behind a desk for 8 hours? Can you move a bit more? Yes, then possibly sitting on a ball for a short period of time and having a wiggle and having a move might be beneficial. But then it's also important to be specific to that patient. Does this help you? Yes, brilliant. Carry on with it. Does this make your pain worse? Brilliant. Maybe try something else. Or not brilliant, but maybe consider trying something else. Not brilliant. Try something else. So it's got to be individual. So there's no hard and fast. Yes, this is perfect for everyone, except everybody should be doing a little bit more movement. Is probably a good way I'd put it. And that's kind of the way I'd put it to the occupational health. Is what actually changes this person's pain? What makes them feel better? Is it standing? Is it sitting? Is it walking? Is it having more regular breaks? Is it having a 15-minute period at lunchtime when they can do some mindfulness and some meditation and some deep breathing? Can they do a 5-minute yoga stretch off, at tea time, whatever it is? What other ways can we improve it? Not necessarily changing that sitting posture and making sure the arm heights are 3 to 3 inches higher probably has a small bearing on the pain overall.
Yeah, I'm still waiting for the study. I used to visit offices quite a lot, and I'd love a study to see whether people who smoke and have regular cigarette breaks actually suffer less from lower back pain than people who are not going out. Because not only do they go out for smoke, if you look at people having cigarettes, they're talking, they're putting a leg up on the wall, they've probably got one hand on the hip, they're just kind of moving a bit more.
Smoking yoga.
Look at me.
Yeah.
It is. And they're getting out, they're getting some fresh air. Okay, they're filling their lungs with tar and nicotine as well, but at least they're moving and they're kind of like, so even stubbing the cigarette out, they're getting some nice hip rotations and plantar flexion. It's just the whole thing.
Love it.
Let's all smoke. So, but I'm wondering whether, and they're allowed to as well. So they got that freedom thing as well. It's definitely, Tina, talking to, when I did it, it was just having a good chat. The only way you're going to convince managers, I think it's across the board, that getting their staff to move more and not have to sit down in front of computers is going to make the company some money. It's just the only language they
improve
talk.
Workplace productivity.
But
what doesn't improve workplace productivity is time off because of pain. That has a huge negative impact on staff morale, everything. So I'd go for that side of it.
Exactly. I think that's one of the biggest losses for a lot of businesses is absent staff and having to get a temp in, or someone leaving, retraining someone. That's the biggest hole in their little water. I feel that with mine. So there is conversations you can have, but it might be tricky because they always link letting people stand up and move around. They can't concentrate while they're standing up. But
nonsense.
Yeah, good one. Thanks, Tina. Good question. I like that. But it's interesting, isn't it? The standing desks, not like you say. I mean, I think it's been shown that if you do stand up for 8 hours at a desk, you're going to get injured, you get pain in different places probably, but it's still going to cause issues. And I think there's a study which showed it actually reduces mental capacity anyway, for some reason. Did you read anything about that? No. You can think more, be more productive sitting down. The brain is kind of like more productive in that position, standing up. But anyway, good. Okay, great questions, people. Keep them coming. I hope that helped you, Tina. If you need a follow-up, just write something in the comments. Okay, right, where are we? Let's go on to number 3 then, if that's all right with you, Rob. So MRIs, what have you got to say about MRIs?
MRIs. So MRIs have taken a bit of a bashing recently, as you've probably seen on social media. They're being blamed for everything under the sun, from failure to improve to increased surgery rates to increased procedures to everything. And so my stance on this, and we've done this on podcast, is The problem isn't necessarily with the MRI. After all, an MRI is something inert. An MRI doesn't make you worse unless you've got some metal in your body that you didn't know about. Then you might make you a bit worse. But an MRI in itself doesn't make you worse. The fault that we have on MRIs is in poor reporting to patients, and this is hard to get your head around. The issues with MRIs is they don't see pain. They don't show something in pain. They show everything under the skin all at once, which may sound brilliant. And the radiologists do a fantastic job. This is what they do all day, every day, is look at scans and report on them. So they tell you everything that's happening right now, that snapshot, everything's happening right underneath your skin. The issue is most people walking around have something on a scan that could probably be blamed on their pain, even if they don't have pain or that finding kind of doesn't match their symptoms. And radiologists aren't looking at the patient. They're not examining the patient. They might have a few lines of a history and a referral note, but they don't really have the full kind of data. So the skill in managing this is how then that report is translated to patients. So I have a bit of an issue with kind of reports being handed out to patients when they haven't been explained. Obviously, it's their report; they've got a right to see it, but it should be given to them with an explanation of kind of what happens. I've got a story about this as a prime example. I had a lady who came to see me, and she had stepped off a curb, and she's an elderly lady, I think she was mid-80s, stepped off a curb, felt a jarring pain in her lower back. Now, that step off a curb, immediate pain is quite a common mechanism of kind of a compression fracture, particularly in an elderly osteoporotic spine. So she saw the GP sent her for an X-ray to kind of rule out this fracture. She then rang back a week later to get the results of her X-ray. She spoke to a different GP who hadn't examined her, who said, yes, you've got some arthritis, but that's fine. Okay. She said, oh, okay, that's sad. She then came to see me, and I said, so what brings you to see me? And she said, oh, well, I stepped off a curb and it gave me arthritis. And that was her thought of what happened. She didn't, she thought that she didn't understand what arthritis was. She didn't understand that this was a normal process that happened to her spine. She thought that, she stepped off a curb and it had given her arthritis. And so that was just poor reporting from, unfortunately, these doctors are hugely busy. They don't have time to sit down and, as we do in most of our private practices, and discuss the results from MRI for half an hour. So, I'm not bashing anyone there as well. But when we're reporting these things to patients, we can say things like, you have severe degeneration, you have spinal arthritis, crumbling spine, which I've heard, which is the worst phrase ever when describing something. Or we can say things like, you have a normal spine for your age, it's just a bit sore right now. And then which one of those narratives would you rather hear? And which one of those narratives is going to get that patient moving? If you're trying to get patients to exercise and they think they've got a crumbling spine, they're going to be a lot more fearful of movement. They're going to be a lot more protective around it. Whereas if we say you have a totally normal spine for your age, it's just a bit sore, we need to get it moving, it reverses the same conversation as they have in their head. It also then plays into previous beliefs. If they've had 4 generations of people with, arthritis, and they've suddenly been told they've got arthritis, even though they just have a very normal spine for an 80-year-old, as far as they remember, their mother, grandmother, and grandfather all had severe back pain. That's then going to play a huge part in their recovery, because if someone's had pain for 20 years because of their arthritis, and we're talking about osteoarthritis here, just kind of to clarify, that's going to play a role in their recovery. So having their beliefs and expectations, understanding those is a huge part of it as well.
It's interesting. I think everybody probably, when you heard Rob saying crumbly spine, everyone's kind of gone, ooh, that's a horrible way of talking about the spine. And we get that. And we might not use the word crumbly, for example, with the people we see and say, oh, the problem is you've got a crumbly spine. But we do use other words, like the famous one of a slipped disc, or my back's gone. I mean, even just saying your back's gone is quite a scary kind of thought of But like slipped discs, for example, and that's another one which I think a lot of people probably, they hear their patients say it, or maybe they use it themselves when they're kind of talking. But that's one, it's not accurate, which I'd like to ask you about, because you've probably seen a lot of slip discs or people with apparent slip discs. And 2, it's something which, again, if you look on the MRI, you're going to see signs of these things, which again might be in asymptomatic individuals, or they even kind of recorrect themselves. So yeah, what do you think about the word slip disc?
Yeah, so I think we often get this kind of comment when we talk about MRIs, because people say, well, I had an MRI and it diagnosed my problem, and that's brilliant. But what's actually happening there is you're not using the MRI to diagnose you. An MRI is correlated with your examination, your reported, your history, how you presented, everything. And this has come up with the most likely diagnosis. And a slip disc is a prime example. We know that most people walking around without pain, they have a 40 to 60% chance of having a bulging disc kind of on a spine. Herniated disc slightly lower, but still quite a high chance without any pain. People can have disc changes at many different levels throughout the spine without any pain at all. People can have huge disc herniations and zero pain. People can have very small disc bulges and a lot of pain. So there's very little correlation with this. Disc injuries slip disc, whatever you like to call them, herniated disc can cause pain as well. So they can bulge, they can irritate a nerve root, but it has to be taken into account with that patient history. If someone's coming into you with raging sciatica and leg pain and weakness and numbness and foot drop, and then they have an MRI which shows that at that same level they also have a large disc herniation, then you can put two and two together and think, yes, this is probably the cause of the pain. Going on to kind of the slip disc, this is a very old-fashioned kind of analogy. I know it's still used, and it's similar to the narrative around things popping in and out of place. It's just kind of maybe a lazy narrative, and it's easy to say, and it's easy for patients to kind of understand, but it does lead to that fear that things slip out and in. And if we did a whole podcast with David Poulter about discs don't slip, and we know that these changes are likely taking place over long periods, and then something sensitizes that area at one time. So that disc slip, bulge, herniation, whatever you call it, has probably been there for a long time. The amount of force needed to have an acute herniation is significant. So without levels of car crash and things like that, it doesn't really happen. What's likely happening is these changes have been taking place over years, and these disc bulges have been there the day before you had the back pain, then also the day after you had the back pain, but something else has sensitized it. And David Poulter talks about his rule of twos, which is too frequent, too often, too much, too many, too much load. I can't remember exactly what they all are, but basically something has sensitized it. Something has irritated it, which the body isn't necessarily used to. Too quick, too strong, too often for too long. That's kind of what he says. So that might be a change in symptoms, a change in activity that sensitized that nerve and that nerve root, and then has led to pain kind of further down the line. And then that nerve root, and then that builds into the whole back pain narrative, other fears, beliefs, catastrophizing, fear of movement that then further keeps those back pain wheels spinning. So, slip discs can cause pain 100%, but do they always cause pain? No.
I think it's useful, not for all therapists, but I think a good intro to changing your practice is by looking at the words you use and understanding how, if that can have an effect on your patients, you understand that gives you an intro to understanding pain a bit better. It means you can start kind of looking at you, being a bit more reflective about your own practice. And if you start criticizing yourself, even if it's just the words you use, then you're going to start criticizing what you do with your hands. And I think it's quite a good backdoor for a lot of therapists to start caring about what's coming out of their mouths and what images they've got up, and whether they have got a little kind of classic model of the spine with a big red bulging thing coming out from the side. What someone in back pain is going to think if they look at that. Are they going to walk out thinking, oh yeah, I feel great, or oh my god, did you see that model? That's what's in my back, that sort of thing. It's a good intro, I think. Robert here says, we had a discussion at LSBU on guidelines on our education on imaging. My suggestion is more time needs to be devoted to explanation to patients without creating threat, but providing reassurance.
100%.
Very true. And Becky comes up, obviously, with a great Louis Gifford quote. Effective reassurance is a bloody good painkiller, said Louis.
100%. Also brilliant.
It's good stuff. And Robert shared his agreement. Great. Okay. So MRIs, you've got to be careful about it. And I think what you said is the biggest message is we don't use an MRI to diagnose. We go to confirm a hypothesis is already created, and let's see if this kind of adds to it and gives it weight. So
I think David Poulter said that diagnosing pain with an MRI is like looking at a wedding photo and trying to guess who the drunkest person is. And I really like that analogy. It's that really you might have some idea, but you don't know. And I thought I just really like that. Really like that analogy.
He seems to have a lot of time to come up with great analogies, though. He seems to spend the last 2 years on a bike, hasn't he? Or
phenomenal. I don't know how he does it. Phenomenal achievement. With
word-to-word descriptions on Twitter. But some amazing stuff from David Poulter. If you haven't followed him yet, then look out, particularly on Twitter. Fairly active, to say the least. Cool. Okay, right. We've been through 3. We're doing okay. I think there's a big tie-in now with the next one anyway, because you kind of mentioned it. But this big take-home message, or this idea that pain equals damage. You mentioned it a few times. the idea that, well, yeah, pain is not an accurate measurement of how much damage you've done to tissue, that you can have it without necessarily having any tissue damage at all. And we've talked on the podcast before about this. We mentioned phantom limb pain. We had the pleasure of Rachel Zoffness, who is on episode 51, I think. I can't remember now. But yeah, I mean, a fantastic educator of pain. So hopefully people who've listened to these other guests on the podcast are aware of this. But have you got any particular ways of helping clients appreciate that just because they're in a lot of pain doesn't mean they've got a really serious, when you're talking to the client, obviously we've learned from other educators that letting the client come up with their own metaphor is pretty cool. But is there some which you kind of resonate with you that you think is quite a nice way of helping educate your clients?
Yeah, so this is really hard to do, and 100% I've got it wrong. I've I know I've got it wrong in the past. There's still times when I know I could have explained this better, because if you do explain pain poorly, the patient walks away either more confused, they think that you think they're making it up, which is never, no one thinks that, someone's pain is really kind of real. So I kind of say to patients that we know that we can have pain in a body part with damage, kind of after trauma. We can have pain in a body part without any damage, like a migraine, severe pain goes away within, sometimes in hours, no pain before, no pain afterwards. Yes, some people might have some cognitive effects, but generally, no lasting damage. We can have damage without any pain at all. If you like a rupture of blood vessel in your eye, you can have, a big bleeding red eye and zero pain at all. And we can also have pain without a body part. So, that can be phantom limb pain. People can be born without a limb, but can have sensations in it. So this kind of adds fuel to the fire that pain is controlled by the brain. And so the story I'll give to patients is that kind of how pain works. And this is if I give it to you in the way that I'd kind of explain it to a patient, is that we have lots of nerves in the body. We don't have pain nerves. We have a whole variety of different nerves. And what nerves have on the end of them is receptors. And these receptors get stimulated by different stimulation. So we have nerves that respond to heat, for example, and we have nerves that respond to pressure. What's often thought of as pain nerves are called nociceptors. And these don't respond to a specific stimulus. They are what we call high threshold receptors, where they respond to a lot of stimulus at once. So the only information they can give to the brain is there's a whole lot of something, a whole lot of crap happening right now, but it can't give any specifics. So what the brain does is all of this information gets fed into the spinal cord, up into the brain. The brain then relies on the information from said body part. It then relies on what you're seeing, your smell, your taste. It also leans on past experiences. For example, if you're getting burnt on something, a stove or a fire, your body might think, oh, I can smell smoke, I can see fire. The last time this happened, I was in some pain too. And then also we've then got all this stuff happening down in my leg. Something must be happening. I'm going to project this pain onto that body part, and then we have the sensation of pain. And that's kind of how pain works at a very basic level. And that's about my level of understanding of pain. I can't really go beyond that. But it's the brain that evaluates this and then makes that decision based on past experience. So then the same thing then happens with pain, say back pain. If, for example, we bent forward and we felt our back, go. And the last time this happened, it also happened when we bent forward and our back went. Our brain relies on that past experience. So then, of course, we're then going to be afraid of moving or bending forward, because all these movements play into pain. So that I use that as an analogy to help patients unwind it and think, okay, so we're terrified of flexion. We don't want to bend forward. Fine. Can we flex the spine in a different way? So can we lie on your back and pull your knees up towards your chest? Can you sit down for a slump position and sit back up again? The same thing is happening in the spine, but it might be a lot less painful. And we know that if we can do it slumps 10 times, it might get a lot more comfortable. And then standing up, we might be able to flex forward, 10 more degrees than we did before. And then that improves that envelope of function. And then we can then use that with another exercise. And these are all the kind of the conversations which I'll have with patients who have this fear around movement, which is normal. Patients, it's normal to be scared of a movement if it hurts to do so. So it's not the patient's fault at all.
Great. Yeah, some nice ideas there. Yeah, the migraine one's really good. I mean, most people have had maybe not a serious migraine, but it's the headache. And yeah, it just goes. And you don't at the time start thinking, I need an MRI. Something's going on in my head, something that you just accepted only because of the narrative we've been,
exactly,
not born to worry about it. And the fact we can kind of look in the mirror and see it, I suppose. I mean, that's part of the thing about back. Do you think, I don't know whether we give too much weight to this, but is it coincidence it's the part of the body we can't really see, or Is that part of the fear? Or
I've never considered that, actually. I think that people associate back pain with spinal cord. This is I don't have any evidence for this. My belief is that people associate back pain with things like, being in wheelchairs and having horrific accidents, and the narrative around spinal fractures and, spinal cord being so vital. That is why it's led to kind of the fear around movement and back pain being so much worse. Also, it can be so painful. And, everyone would have seen people in horrific pain. They're curled up in the fetal position in reception when you go down to get them. Back pain can be some of the worst pain imaginable. The acute sciatica patients, I feel so sorry for. It is horrific pain. So I think arguably it is also really, really bloody painful. And I'm fortunate that I've never been in severe sciatic pain. So I can't, empathize, but I can sympathize because I've seen a lot of it.
Okay, right, time is winning, so let's talk about briefly the last one you chose, and they're in no particular order, but it's another one which I think a lot of soft tissue therapists who decide to get into some kind of handing out exercises, they look at this, the weak core. Tell us about weak cores and lower back pain.
Yeah, so this has been around for years. Everyone would have done some core stability exercises at some point, I'm sure, or given them to a patient. Now, this came about from the idea that all muscles, ligaments, tendons kind of work together to create our stable spine, or a kind of a stable system. And then that led, or kind of got extrapolated by, I think it was Paul Hodges who kind of started this again in the early 90s, I think, who basically hypothesized that if muscles weren't doing their job, this could be a precursor to pain. So they measured the transverse abdominis muscle in people and got them to lift their arms up. And they found that people who had back pain had a later firing of the transverse abdominal muscle compared to people without back pain. And this then led to the thoughts that it should be firing earlier. And this was kind of a cause of back pain. This led to people strengthening transverse abdominis and also the multifidus and strengthening the core, thinking that was actually going to then help back pain. When actually we know that people whose back pain improved, they didn't necessarily have a better firing of the transverse abdominis. They didn't necessarily improve their core strength. So Greg Lehman talked about this as what he called kind of an epiphenomenon, i.e. it occurred at the same time, but isn't necessarily directly related. And I think the analogy he gave, which is brilliant, I've forgotten which podcast it was, he said, it's like people with acute lower back pain, they have an acute sympathetic response, they get sweaty. So it's like saying everyone with lower back pain, we need to give them towels because, they're all sweaty. And I thought that's such a good analogy. It's something that's parallel to dysfunction, but is not necessarily a driver of the pain. So this led to people activating these muscles, strengthening these muscles, and people got better. But it wasn't necessarily because we're strengthening the core. And I think that's what I come back to. None of these exercises are bad, and people giving out core stability exercises, fantastic. If this is helping patients, brilliant. I still give out core stability exercises, but I'm not telling patients that they're strengthening their core. And I think that's kind of the narrative around. We've come back to the narrative about how we're explaining things. That's the important thing. So it's certainly okay to use these exercises, whether that's a bird dog, a single leg bridge, a standing balance, whatever it might be, a sit up. No problem with using any of these exercises. They're just ways of loading and bending and stressing the spine, which we know it likes and it tolerates, and it gets better because of that. In actual fact, people who have back pain have an overactive core. So often these people walk around bracing their core, which is the worst thing to do. If you injured your elbow, you wouldn't walk around holding it at 90 degrees all day and expecting it to get better. These people often have overactive cores and need to focus more on kind of relaxation and movement and being free. So again, I'm not slagging off core exercises. There's no problem with giving core exercises. They're good exercises. There's no problems, but they're not any better than any other specific exercise or non-specific exercise for kind of lower back pain.
There you go, people. So yeah, still give out the exercises, but again, like I think how we started, pretty much, if you tell someone, patients don't come to and say, I know what the problem is. Yeah, I've got a weak core. Unless if they do, it's because they've been to another practitioner to tell them that. But patients and clients don't come to that assumption themselves. It's somewhere along the line, it's a therapist, isn't it, and a healthcare professional who's told them that.
Yeah,
and once
or the Daily Mail.
That seed, or the Daily Mail, exactly. But once you've sowed that seed, it can be very destructive, and they're more likely to devote all of their time to strengthening their core instead of looking at the myriad, like you started off saying, of other factors which could be contributing to this pain not going. And the very fact they're besotted by strengthening their core could be creating this obsession, which is delaying recovery. And so,
100%, yeah.
But I love the way you say, Doesn't mean you have to stop doing it. We're not kind of dismissing it and saying, that it's a waste of time. It's just understanding how to present it, how to package it up. It's good stuff. I like it. Okay, mate, great. Well, look, I think we've done pretty well in just over an hour going through those 5 areas. And
you could have spoken about each one of those for an entire hour.
Oh, for sure. Yeah. But hopefully, thanks to you, it's given, for some people listening to this, particularly on the podcast, and I love the idea that people turn to the Sports Therapy Association podcast for a little bit of kind of education, but in a nice way and not being shouted at. Social media is so shouty these days and calling out BS and kind of like there's capital letters and swearing. And it shouldn't be like that, because anybody who's definitely my age has talked about all of these things before. I was giving out, I was talking to people about their transfers abdominis in 2000 and giving them stability ball exercises for their bench presses and doing squats and fit balls. It's normal. You grab what's there because you're excited. You want to help people, but it's evolving, isn't it?
It doesn't come from bad places, and that's it doesn't come from a bad place. We're all here to learn. I was exactly that. I did exactly the same thing. I was activating cores. I was improving people's postures. Same thing. Yeah.
So there's nothing wrong with it, but I think the danger these days, again, because it's so polar, rather than being encouraged just to change little things here and there and evolve, people just get attacked a little bit too much, and it's like everything you do is rubbish, ha ha ha, and look at me, listen to me. So hopefully, anyway, if all 5 of these things have kind of given you food for thought, then maybe just take a couple of them. We'll put references to places. Fortunately, on you've got a whole load of podcasts here. Let's bring this up again now, which you can listen to which will reinforce and talk about with other guests about these topics. So, for example, if the posture was interesting for you, then you've got episode here. What difference does posture make for back pain? If you're interested in manual therapy, what it does and doesn't do, then
that's a really important
scroll through. I think you're on. How many episodes have you done now? It's a lot, isn't there?
62.
There you go. I know it's 60 something. So there's an awful lot of information there, free, of course. You guys asking for what CPD? Well, here's another place. And you can listen to that podcast. And Gary said before, if you provide that as, on your CPD form, I listened to this episode on the back pain podcast and it taught me this, bam, there's an hour of quality CPD you haven't paid a penny for. You don't have to go and do a course of what to do with your hands to get good CPD.
We've got 70 hours worth, so
There's 70 hours there. So so do go and check it out. If you listen to the podcast and you can't see what's on the screen, then the easiest way to get that, if you're already savvy with podcasts, and just do a search for the back pain podcast, it's a nice orange logo with a spine without any bulging discs coming out of it. I think it'd be so ironic if you did have a red little bulging thing on there. But anyway, so that's the logo, and if not, you can find it on the backpainpodcast.com with all kind of signposts there. You can even listen to it on your website, can't you, which is nice. Right. Thank you so much for your time, Rob.
Anytime, mate. Thanks for having me.
What have you got? Questions. Things have opened up a little bit now. Before, like half a year ago, I was like, what do you think I'm going to do? We're stuck in a pandemic. But are things changing for you a little bit now that it's kind of, it was nearly kind of freed up? But
I've got a 1-year-old, so now I can actually take him places. So I can, I went to soft play for the first time ever. It's brilliant. You don't have to parent for an hour, little things like that. So we've been stuck inside the house with a 1-year-old for 12 months, which anyone who's a parent, I'm sure, understands the difficulties. But no, things are opening up so we can actually leave the house, which is always beneficial, and work's opening up. And we were very fortunate that we were in a position that we were allowed to work kind of throughout the pandemic, which I know a lot of people weren't. So we were fortunate in that. So we're kind of getting back to it and getting back to all of the things which we enjoy.
Fantastic. I don't know how long that love of soft play will last. I understand it's a nice release now, but that was something.
I've only been once.
I've got my get out soft. If you're going to soft play, well, Daddy doesn't come then. Daddy doesn't do soft play.
Our one does beer, so.
Great. Well, thank you so much. And like I say, people, there's a lot of information on the website. There's a blog there as well with lots of interesting articles and things to look through. And like I say at the beginning, it's all phrased really nicely. It's not going to make you feel imposter syndrome kicking off and all that sort of stuff. So there you go. Right. Thanks for joining us, people. Next week, to end this month of June, we've got, talking of CPD, we've got Mike James is coming in the house or the endurance physio. Some of you will be very familiar, especially if you join us live with Mike James. But we're going to have a nice chat about CPD, the past and the future. Obviously, we've seen some massive changes in how CPD is delivered. Has the kind of time we actually went somewhere in person disappeared now? Is it all online? Is there too much online? How much should you still be paying for it, and that sort of stuff? So Sports Injury Fix has recently had a massive kind of upgrade based on what they've learned during COVID and questionnaires they've had. So they've really changed it round and given what they think will be really useful to therapists. So Mike's going to come and tell us all about that. So same time next week, Tuesday at 8 o'clock UK time on the Sports Therapy Association. So on behalf of myself and Rob and the Back Pain Podcast, thanks for tuning in. And yeah, Rob, thanks again to you for coming and giving us your time.
No, I'm honoured that you had me on. Thank you very much.
Good stuff. See you later, people. Thank you very much.